Question 1. A 30-year-old woman presents to the clinic with complaints of heavy menstrual bleeding, pelvic pain, and an enlarged uterus. On examination, she has been diagnosed with uterine fibroids in the past. The patient is considering a hysterectomy due to the severity of her symptoms. What is the most appropriate next step in her management? A. Immediate referral for hysterectomy. B. MRI to assess the size and location of fibroids. C. Prescribe hormonal therapy to reduce symptoms. D. Schedule a laparoscopy for fibroid removal. Answer: B. MRI to assess the size and location of fibroids. Explanation: the management of uterine fibroids should be guided by symptom severity and the patient's desire for fertility preservation. Before proceeding with surgical options like hysterectomy, it is important to assess the size, location, and number of fibroids. MRI is non-invasive and highly accurate diagnostic tool for evaluating fibroids and can help guide treatment such as myomectomy or uterine artery embolization. Hormonal therapy, such as progestin agonists, can be used for symptom management but may not address the underlying condition sufficiently in severe cases. Laparoscopy may be appropriate in some cases, but it's important to first assess the fibroid's characteristics through imaging. Question 2. A 26-year-old woman presents to the clinic with a history of irregular menstrual cycles and difficulty conceiving for the last year. She has a BR of 32 and her physical examination reveals hirsutism. What is the most likely diagnosis and what would be the most appropriate first-line treatment? A. Polycystic ovary syndrome, PCOS combined oral contraceptives. B. Endometriosis laparoscopy. C. Premature ovarian insufficiency, estrogen therapy. D. Hypothyroidism, thyroid hormone replacement. Answer: A. Polycystic ovary syndrome, PCOS combined oral contraceptives. Explanation: Polycystic ovary syndrome, PCOS, is the most common cause of irregular menstruation and infertility in women of reproductive age. The diagnosis of PCOS is often based on clinical features such as irregular cycles, hirsutism, and obesity combined with ultrasound findings of polycystic ovaries. Combined oral contraceptives (COX) considered first-line treatment for managing symptoms of PCOS, particularly hirsutism and irregular menses, due to their ability to regulate the menstrual cycle and reduce androgen levels. Laparoscopy and estrogen therapy would be indicated for different diagnoses, e.g., endometriosis and premature ovarian insufficiency, respectively. Thyroid hormone replacement is not appropriate unless hypothyroidism is confirmed by thyroid function tests. Question 3. Scenario-based. Mr. Jacobs, a 40-year-old male with a history of hypertension and type 2 diabetes, presents with his 38-year-old wife, Mrs. Jacobs, who is 12 weeks pregnant. During the consultation, Mrs. Jacobs reveals that her first pregnancy resulted in a preterm delivery due to gestational hypertension. What would be the most appropriate management plan for Mrs. Jacobs' current pregnancy given? History: A. Initiate daily low-dose aspirin therapy at 12 weeks. B. Start antihypertensive medications immediately. C. Schedule early delivery at 34 weeks to prevent recurrence. D. Advise Mrs. Jacobs to increase her physical activity to lower blood pressure. Answer: A. Initiate daily low-dose aspirin therapy at 12 weeks. Explanation: Mrs. Jacobs' history of gestational hypertension in her first pregnancy places her at increased risk for developing hypertensive disorders again, including preeclampsia. The current evidence-based guidelines recommend starting low-dose aspirin therapy 81 mg daily beginning at 12 weeks of gestation to reduce the risk of preeclampsia in women at high risk. Antihypertensive medications are not typically started unless blood pressure reaches the threshold for treatment, and early delivery is not indicated unless signs of preeclampsia or other complications arise. Increasing physical activity may be beneficial in managing overall health but is not a direct intervention for preventing hypertension or preeclampsia in pregnancy. Question 4. A 28-year-old woman presents with pelvic pain and irregular menstruation. She has a history of painful periods and recently developed dyspareunia. On ultrasound, her ovaries are noted to have multiple cysts and the uterus appears normal. What is the most likely diagnosis and what is the recommended treatment approach? A. Endometriosis laparoscopy for diagnosis and treatment. B. Pelvic inflammatory disease, antibiotics. C. Polycystic ovary syndrome, PCOS combined oral contraceptives. D. Ovarian cancer, surgical removal. Answer: A. Endometriosis laparoscopy for diagnosis and treatment. Explanation: Endometriosis often presents with symptoms of pelvic pain, dysmenorrhea, and dyspareunia, painful intercourse. While the ultrasound may reveal cysts on the ovaries, endometriomas, the definitive diagnosis of endometriosis is made through laparoscopy, which allows for visualization and biopsy of the endometrial tissue. Combined oral contraceptives may be used for symptom management, but they do not provide a definitive diagnosis or treatment for endometriosis. Pelvic inflammatory disease (PID) is typically associated with fever and vaginal discharge, which are not present in this case. Ovarian cancer is unlikely in this young patient without risk factors such as family history, and the imaging findings are more consistent with cysts, not malignancy. Question 5. A 34-year-old woman who is 18 weeks pregnant presents with an abnormal ultrasound showing an elevated nuptial translucency. What is the next best step in managing her care? A. Reassure the patient that the baby is likely healthy. B. Offer amniocentesis for genetic testing. C. Refer to a high-risk obstetrician for further management. D. Recommend lifestyle modifications and repeat ultrasound in 4 weeks. Answer. B. Offer amniocentesis for genetic testing. Explanation. An elevated nuptial translucency (NT) measurement on ultrasound can be a marker for chromosomal abnormalities, such as Down syndrome or other trisomies. In this case, the best next step is to offer amniocentesis for genetic testing. Amniocentesis provides definitive information by analyzing fetal cells for chromosomal abnormalities. While an elevated NT alone is not diagnostic, it warrants further evaluation. Reassurance is not appropriate without further testing, and referring to a high-risk obstetrician may be appropriate if the patient chooses non-invasive testing, such as non-invasive prenatal testing (NIPT), but amniocentesis remains a gold standard diagnostic confirmation. Question 6. A 25-year-old woman presents with a history of painful, heavy periods and deep pelvic pain during intercourse. Her physical examination reveals a tender adnexal mass. She is diagnosed with a ruptured ovarian cyst. What is the most appropriate initial management? A. Immediate laparotomy to remove the cyst. B. Hospital admission for observation and pain management. C. Administration of hormonal therapy to reduce cyst size. D. Referral to a fertility specialist for surgical management. Answer. B. Hospital admission for observation and pain management. Explanation. A ruptured ovarian cyst can cause acute pelvic pain, but most cases are self-limiting and can be managed conservatively. The initial management includes hospital admission for observation and pain control. This is important to monitor for any complications such as hemorrhage. Surgical intervention is rarely required unless there is significant bleeding or ongoing symptoms. Hormonal therapy is not indicated for immediate management of a ruptured cyst, though it may be used in cases of recurrent cysts or in patients with endometriosis. Referral to a fertility specialist would only be necessary if fertility preservation or more advanced treatment options are needed. Question 7. A 31-year-old woman presents at 24 weeks gestation with elevated blood pressure readings of 159 mmHg on 2 separate occasions with no signs of proteinuria. She has a history of hypertension but has been well controlled on medication. What is the most likely diagnosis and what is the next step in her management? A. Gestational hypertension. Initiate antihypertensive medication. B. Preeclampsia. Perform a 24-hour urine collection for protein. C. Chronic hypertension with superimposed preeclampsia. Monitor closely. D. Normal pregnancy. No intervention needed. Answer. A. Gestational hypertension. Initiate antihypertensive medication. Explanation. Gestational hypertension is defined as elevated blood pressure (BP) after 20 weeks of gestation without signs of proteinuria. In this case, the patient has elevated BP without proteinuria, which is typical of gestational hypertension. Management usually includes monitoring the blood pressure and initiating antihypertensive therapy if necessary. Reduce the risk of complications such as preeclampsia or fetal growth restriction. Preeclampsia would require the presence of proteinuria or other systemic signs, and chronic hypertension with superimposed preeclampsia would present with proteinuria or organ dysfunction. No immediate intervention is warranted unless BP readings continue to rise or other complications develop. Question 8. A 40-year-old woman presents with irregular bleeding and a pelvic mass on examination. Ultrasound reveals a 6 cm mass on the ovary, and Ca-125 levels are elevated. What is the most likely diagnosis and what is the appropriate next step? A. Benign ovarian cyst observed with follow-up ultrasound. B. Ovarian cancer, refer for surgical evaluation. C. Endometriosis, laparoscopy for diagnosis and treatment. D. Uterine fibroids, MRI for further evaluation. Answer: B. Ovarian cancer, refer for surgical evaluation. Explanation: an elevated Co-125 level along with a pelvic mass in a woman over 40 years old raises concern for ovarian cancer. While Co-125 can be elevated in other conditions such as endometriosis or benign ovarian cysts, it is most commonly associated with ovarian malignancies. The appropriate next step is to refer surgical evaluation, which may include staging and removal of the mass. Benign ovarian cysts do not typically cause elevated Co-125 levels, and endometriosis would not explain such significant findings on imaging. Uterine fibroids, while common, would be identified on a pelvic ultrasound as uterine masses rather than ovarian masses. Question 9. A 29-year-old woman with a history of one previous cesarean section presents at 39 weeks gestation in labor. The obstetrician is concerned about the risk of uterine rupture due to the patient's previous cesarean. What is the most appropriate management for this patient? They proceed with a trial of labor after cesarean TOLAC with continuous monitoring. B. Elective repeat cesarean delivery due to risk of uterine rupture. C. Immediate cesarean delivery due to the risk of rupture. D. Induced labor with oxytocin to minimize the need for cesarean. Answer A. Proceed with a trial of labor after cesarean TOLAC with continuous monitoring. Explanation: the management of a patient with a prior cesarean section depends on the individual risks and benefits. A trial of labor after cesarean TOLAC is appropriate for many women with one prior cesarean, especially if the indication for the previous cesarean was not related to a contraindication to vaginal delivery. Continuous monitoring of the process is essential to detect signs of uterine rupture early. Elective repeat cesarean may be indicated if there are concerns about the patient's specific risk factors, such as history of uterine rupture or other complications. Immediate cesarean or induction with oxytocin are not indicated unless there are specific clinical reasons to avoid trial of labor. Question 10. A 32-year-old woman with a history of recurrent miscarriage presents at 10 weeks gestation. She has been diagnosed with antiphospholipid syndrome. What is the most appropriate treatment to reduce the risk of pregnancy loss? A. Low-dose aspirin and heparin. B. Progesterone supplementation. C. Weekly ultrasound to monitor fetal well-being. D. Initiation of metformin therapy. Answer A. Low-dose aspirin and heparin. Explanation: antiphospholipid syndrome (APS) increases the risk of pregnancy complications, including recurrent miscarriage and preterm birth. The most effective treatment to reduce the risk of pregnancy loss in women with APS is a combination of low-dose aspirin and heparin, which helps prevent thrombotic events that could compromise fetal development. Progesterone supplementation may be used in cases of luteal phase defect, but it is not specific to APS. Weekly ultrasound monitoring is important in high-risk pregnancies, but does not address the underlying condition. Metformin is used for managing polycystic ovary syndrome, PCOS, or gestational diabetes, but it is not indicated in APS management. Question 11. A 26-year-old woman presents with complaints of vaginal discharge, dysuria, and lower abdominal pain. She reports recent unprotected sexual intercourse with a new partner. On examination, her cervix is tender and shows mucopurulent discharge. A urine pregnancy test is negative. What is the most likely diagnosis and what is the recommended treatment? A. Bacterial vaginosis, metronidazole. B. Chlamydia infection, doxycycline. C. Trichomoniasis, metronidazole. D. Pelvic inflammatory disease, PID, intravenous antibiotics. Answer B. Chlamydia infection, doxycycline. Explanation: the patient's symptoms of vaginal discharge, dysuria, and lower abdominal pain, along with mucopurulent discharge from the cervix, are suggestive of sexually transmitted infection, with chlamydia being the most likely diagnosis. The first-line treatment for chlamydia is doxycycline. Bacterial vaginosis is usually characterized by fishy odor and thin, gray discharge, not mucopurulent discharge seen here. Trichomoniasis presents with frothy, greenish-yellow discharge, often accompanied by vaginal irritation. PID may present with similar symptoms, but is typically a more severe condition, requiring hospitalization and intravenous antibiotics. Question 12. A 34-year-old woman with a history of type 1 diabetes presents for a routine prenatal visit at 18 weeks gestation. She reports feeling well, but a recent urine dipstick test shows 1 proteinuria. What is the most appropriate next step in her management? A. Repeat the urine dipstick test in 1 week. B. Perform a 24-hour urine collection for protein. C. Start antihypertensive medications. D. Refer to a maternal fetal medicine specialist for evaluation. Answer: B. Perform a 24-hour urine collection for protein. Explanation: proteinuria in pregnancy can be a sign of preeclampsia, which is especially concerning in women with pre-existing conditions like diabetes. A single urine dipstick test may not provide accurate information about the extent of proteinuria, so a 24-hour urine collection is the next step to quantify protein loss and assess for preeclampsia. 24-hour urine collection shows significant proteinuria greater than 300 mg. It may suggest preeclampsia or another renal issue. Starting antihypertensive medications or referring to a specialist may be appropriate based on the severity of findings, but the first step is quantifying the proteinuria. Question 13. A 42-year-old woman presents with a 3-month history of fatigue, weight gain, cold intolerance, constipation, and dry skin. On examination, her thyroid is not palpable and her reflexes are delayed. Her TSH is 12 umol, normal 0.4, 4.0 umol, and her free T is low. What is the most appropriate next step in management? A. Start levothyroxine replacement therapy. B. Repeat thyroid function tests in 6 weeks. C. Refer to an endocrinologist for biopsy. D. Order an antithyroid peroxidase antibody test. Answer A. Start levothyroxine replacement therapy. Explanation: the patient's clinical presentation and laboratory findings are consistent with hypothyroidism. An elevated TH along with low free T is diagnostic of primary hypothyroidism, which requires levothyroxine therapy to normalize thyroid function. Repeating thyroid function tests is unnecessary when the diagnosis is clear. Although autoimmune thyroiditis e.g. Hashimoto's thyroiditis is the most common cause of hypothyroidism, testing for antibodies is not immediately necessary unless there are additional concerns, such as goiter or signs of thyroiditis. Question 14. A 55-year-old woman presents with progressive dysphagia, particularly with solid foods and unintentional weight loss. She has a history of heartburn and regurgitation. On endoscopy, a large, smooth mass is observed in the distal esophagus. Biopsy reveals squamous cell carcinoma. What is the most likely risk factor for her condition? A. Chronic gastroesophageal reflux disease (GERD). B. Heavy alcohol use. C. Smoking. D. Obesity. Answer: C. Smoking. Explanation: squamous cell carcinoma of the esophagus is strongly associated with smoking and heavy alcohol use. These lifestyle factors increase the risk of developing esophageal cancer by causing chronic irritation and damage to the esophageal mucosa. While GERD can lead to esophageal adenocarcinoma, it is not typically associated with squamous cell carcinoma. Obesity is a known risk factor for esophageal adenocarcinoma but not for squamous cell carcinoma. Question 15. A 30-year-old woman presents with a 3-day history of fever, sore throat, and a bright red, sandpaper-like rash that started on her neck and spread to her trunk and extremities. Her tongue is coated with a white exudate, and when scraped, the underlying tissue appears red. What is the most likely diagnosis, and what is the recommended treatment? A. Measles, supportive care. B. Scarlet fever, penicillin. C. Strep throat, amoxicillin. D. Infectious mononucleosis, supportive care. Answer: B. Scarlet fever, penicillin. Explanation: the patient's presentation of fever, sore throat, sandpaper-like rash, and a red tongue with white exudate is characteristic of scarlet fever, a complication of group of Streptococcus gas-pharyngitis. The recommended treatment for scarlet fever is penicillin, which effectively treats the underlying gas infection. Measles presents with a prodrome of cough, conjunctivitis, and Kopriv's spot. The rash appears, so it is not the likely diagnosis here. Strep throat alone would not explain the characteristic rash seen in this case. An infectious mononucleosis typically presents with exudative pharyngitis, but it does not cause the sandpaper-like rash. Question 16. A 45-year-old man presents with a history of chronic cough, hemoptysis, and weight loss over the past 2 months. He has a 30-pack-year smoking history and is in good overall health otherwise. The chest X-ray reveals a solitary pulmonary nodule in the upper lobe of the right lung. What is the next best step in management? A. Repeat chest X-ray in 6 weeks. B. Perform a bronchoscopy with biopsy. C. Obtain a CANI of the chest. D. Start empiric antibiotics for community-acquired pneumonia. Answer: C. Obtain a echini of the chest. Explanation: the patient presents with symptoms that raise concern for a lung malignancy, particularly given his smoking history. A chest X-ray showing a solitary pulmonary nodule warrants further evaluation with a echini of the chest to better characterize the lesion size, location, and any surrounding features. A echini will also help in determining the need for biopsy or further intervention. Repeating the E is insufficient, and bronchoscopy may be indicated later if the nodule is accessible. Starting antibiotics is inappropriate without further workup, as the presentation is more concerning for cancer than an infectious process. Question 17. A 60-year-old man presents with progressive shortness of breath, orthopnea, and bilateral lower extremity edema. His physical exam shows crackles at the lung bases, jugular venous distension, and pitting edema. An echocardiogram reveals a reduced ejection fraction of 35%. What is the most appropriate initial treatment for this patient? A. Loop diuretics. B. Angiotensin-converting enzyme. ACE inhibitors. C. Beta blockers. D. Digoxin. Answer: A. Loop diuretics. Explanation: this patient presents with signs and symptoms of congestive heart failure, CHF, with reduced ejection fraction, heart failure with reduced ejection fraction, HFrEF. The initial treatment for managing fluid overload in CHF involves the use of loop diuretics, which will help alleviate symptoms of edema and shortness of breath. ACE inhibitors and beta blockers are also important in the long-term management of HFrEF, but are not the first step in treating acute symptoms. Digoxin may be used in certain situations, such as in patients with atrial fibrillation, but it is not the first-line treatment for managing fluid overload in EHF. Question 18. A 27-year-old woman presents with fatigue, palpitations, and lightheadedness. Her vital signs show a heart rate of 150 beats per minute, blood pressure of 110 cm, and temperature of 98.4 dec, 36.9 dec. And it reveals narrow QRS complexes with regular rhythm at rate of 150 beats per minute. What is the most likely diagnosis? A. Atrial fibrillation. B. Atrial flutter. C. Supraventricular tachycardia, SVT. D. Ventricular tachycardia. Answer: C. Supraventricular tachycardia, SVT. Explanation: the patient's presentation of irregular narrow complex tachycardia with a heart rate of 150 beats per minute is most consistent with supraventricular tachycardia, SVT, a broad category of tachyarrhythmias originating above the ventricles, and it often presents with irregular rhythm and narrow QRS complexes. Atrial fibrillation and atrial flutter typically present with an irregular rhythm, and ventricular tachycardia usually has wide QRS complexes and may present with more severe symptoms. Question 19. A 33-year-old woman presents with new-onset joint pain and stiffness, particularly in her hands and wrists, that has been present for the past 3 months. She also has morning stiffness lasting over 1 hour and occasional fever. On physical exam, she has symmetric swelling and tenderness of the metacarpophalangeal and proximal interphalangeal joints. What is the most likely diagnosis? A. Osteoarthritis. B. Rheumatoid arthritis. C. Systemic lupus erythematosus. D. Psoriatic arthritis. Answer: B. Rheumatoid arthritis. Explanation: the patient's presentation is most consistent with rheumatoid arthritis, RA, which often causes symmetric joint pain, morning stiffness lasting longer than 1 hour, and swelling of the metacarpophalangeal and proximal interphalangeal joints. RA is an autoimmune disorder that commonly affects the small joints of the hands and wrists. Osteoarthritis typically causes pain in weight-bearing joints and does not cause prolonged morning stiffness. Systemic lupus erythematosus, SLE, can cause joint pain, but is usually accompanied by characteristic rash. Psoriatic arthritis can also cause joint pain, but often involves the distal joints of the fingers and toes, with associated skin changes. Question 20. A 70-year-old man presents with a history of progressive difficulty swallowing both solids and liquids over the past 6 months. He reports a sensation of food getting stuck in his chest. His medical history includes long-standing gastroesophageal reflux disease, GERD. An upper endoscopy reveals a stricture in the distal esophagus with a smooth circular narrowing. What is the most likely diagnosis? A. Chalasia. B. Esophageal cancer. C. Gastroesophageal reflux disease, GERD. D. Esophageal stricture. Answer: D. Esophageal stricture. Explanation: this patient's history of progressive dysphagia, particularly with both solids and liquids, along with smooth circular narrowing seen on endoscopy, is most consistent with an esophageal stricture, which can be complication of long-standing GERD. Strictures develop due to chronic inflammation and fibrosis from the acid reflux, leading to narrowing of the esophagus. Chalasia, typically present with dysphagia, primarily affects liquids and is associated with failure of the lower esophageal sphincter to relax. Esophageal cancer would present with weight loss, more significant dysphagia, and often an irregular mass on imaging or endoscopy. GERD alone does not typically cause such pronounced stricture without the development of chronic damage. Question 21. A 52-year-old man with a history of diabetes and hypertension presents to the emergency department with sudden onset of left-sided weakness, slurred speech, and facial droop. His symptoms started 2 hours ago. His blood pressure is 179 mmHg and his blood glucose is 200 ppm. A non-contrast CT scan of the head is performed and shows no acute findings. What is the appropriate next step in management? A. Administer PA, tissue plasminogen activator. B. Perform a lumbar puncture to evaluate for subarachnoid hemorrhage. C. Initiate anticoagulation therapy. D. Transfer to a stroke center for further evaluation. Answer: D. Transfer to a stroke center for further evaluation. Explanation: the patient is presenting with classic signs of an acute ischemic stroke, which typically manifests as sudden onset of neurological deficits such as weakness, slurred speech, and facial droop. The normal non-contrast CT scan does not rule out an ischemic stroke, as CT scans are not as sensitive to early ischemic changes. Given the time frame, symptoms began hours ago. The most appropriate next step is to transfer the patient to a stroke center for further evaluation, including a more detailed workup, GMRI, carotid ultrasound, or angiography. Administering TPA, a thrombolytic, can only be done within a narrow window, within 3 to 4.5 hours of symptom onset, but the patient should first be evaluated further to rule out hemorrhagic stroke or other causes before. A lumbar puncture is unnecessary at this point, and then anticoagulation is not indicated for ischemic stroke unless there's evidence of atrial fibrillation or another thromboembolic source. Question 22. A 45-year-old woman presents with a 1-week history of fever, chills, and a sore throat. On examination, her tonsils are enlarged erythematous and covered with a white exudate. Her uvula is deviated to the right, and there is palpable lymphadenopathy in the right neck. A rapid strep test is positive. What is the most appropriate next step in management? A. Prescribe amoxicillin. B. Prescribe doxycycline. C. Perform a throat culture. D. Prescribe prednisone for tonsillar swelling. Answer: A. Prescribe amoxicillin. Explanation: the patient's presentation is highly suggestive of streptococcal pharyngitis, strep throat, including fever, sore throat, tonsillar exudates, and palpable cervical lymphadenopathy. The positive rapid strep test supports this diagnosis. The first-line treatment for streptococcal pharyngitis is a beta-lactam antibiotic such as amoxicillin, which is effective against group Streptococcus. Culture may be performed if there is a high clinical suspicion of strep throat despite a negative rapid test, but in this case, the positive rapid strep test is sufficient. Doxycycline is not appropriate for treating streptococcal infection, and while prednisone may help with inflammation, it is not indicated as first-line therapy for this condition. Question 23. A 32-year-old woman presents with a 3-day history of left lower abdominal pain, fever, and nausea. She is sexually active and has had multiple partners. On examination, she has tenderness in the left lower quadrant and cervical motion tenderness. A pelvic ultrasound reveals a thickened fluid-filled fallopian tube. What is the most likely diagnosis? A. Ectopic pregnancy. B. Ovarian torsion. C. Pelvic inflammatory disease PID. D. Appendicitis. Answer: C. Pelvic inflammatory disease PID. Explanation: the patient's presentation of lower abdominal pain, fever, nausea, and cervical motion tenderness, along with the ultrasound finding of a thickened fluid-filled fallopian tube, is most consistent with pelvic inflammatory disease PID. PID is an infection of the female upper genital tract, often caused by sexually transmitted infections, e.g. chlamydia or gonorrhea. It typically presents with abdominal pain, fever, and findings such as cervical motion tenderness or annexal tenderness on exam. Ectopic pregnancy should be considered in any sexually active woman with abdominal pain and a positive pregnancy test, but this patient's presentation does not fit with the typical presentation of ectopic pregnancy. Ovarian torsion often presents with acute, severe pelvic pain, and appendicitis typically presents with right lower quadrant pain. Question 24. A 24-year-old woman presents with a 2-day history of a painful red, swollen right knee. She reports recent trauma to the knee while playing basketball. On examination, the knees are erythematous, swollen and warm to the touch with limited range of motion due to pain. There is no fever or systemic symptoms. What is the most likely diagnosis? A. Septic arthritis. B. Gout. C. Osteoarthritis. D. Preputilar bursitis. Answer D. Preputilar bursitis. Explanation: this patient's presentation of localized swelling, erythema, and warmth over the anterior knee, especially following recent trauma, is most consistent with preputilar bursitis, which involves inflammation of the bursa in front of the kneecap. It can result from direct trauma or repeated pressure, commonly seen in athletes or those who kneel frequently. There is no systemic involvement. G. Fever, which would be more suggestive of septic arthritis. Gout typically causes severe pain in a single joint, often in the first metatarsophalangeal joint, and is associated with hyperuricemia. Osteoarthritis generally involves chronic, progressive joint pain with mechanical symptoms such as crepitus or stiffness, and usually affects weight-bearing joints. Question 25. A 60-year-old man with a history of chronic alcohol use presents with confusion, ataxia, and ophthalmoplegia. He has difficulty walking and is unable to stand without assistance. On examination, he has horizontal nystagmus and a wide-based gait. What is the most likely diagnosis? A. Alcoholic hepatitis. B. Wernicke's encephalopathy. C. Korsakoff syndrome. D. Cerebellar stroke. Answer: B. Wernicke's encephalopathy. Explanation: the patient's symptoms of confusion, ataxia, ophthalmoplegia, horizontal nystagmus, and a wide-based gait are classic signs of Wernicke's encephalopathy, a condition caused by thiamine, vitamin B deficiency commonly seen in chronic alcoholics. Wernicke's encephalopathy is a medical emergency and can progress to permanent neurological damage if untreated. The hallmark triad includes ataxia and ophthalmoplegia. Korsakoff syndrome is a chronic consequence of Wernicke's encephalopathy and is characterized by memory impairment and confabulation, but it is not the initial presentation. Alcoholic hepatitis typically presents with liver dysfunction, and cerebellar stroke would present with more focal neurological deficits. Question 26. A 45-year-old man presents with a 2-week history of persistent cough, fever, and night sweats. He reports recent unintentional weight loss and hemoptysis. He has a history of smoking and worked in construction. On examination, there are decreased breath sounds and dullness to percussion over the right lower lung. What is the most likely diagnosis? A. Acute bronchitis. B. Pneumonia. C. Tuberculosis. D. Lung cancer. Answer: C. Tuberculosis. Explanation: this patient presents with classic signs of tuberculosis (TB), including a persistent cough, fever, night sweats, weight loss, and hemoptysis. His smoking history and occupation may increase his risk of lung disease, but the presence of night sweats and unintentional weight loss is more suggestive of an infectious process like a chest X-ray and sputum culture for Mycobacterium tuberculosis. For diagnosis, acute bronchitis and pneumonia can present with cough and fever but would not typically cause the weight loss and hemoptysis seen here. Lung cancer is a possibility, especially in smokers, but TB is more likely given the patient's symptoms and risk factors. Question 27. A 62-year-old woman with a history of hypertension and hyperlipidemia presents with sudden onset severe headache, nausea, and vomiting. She describes the headache as the worst headache of her life. On examination, she has photophobia and a positive Brzezinski sign. What is the most likely diagnosis? A. Migraine headache. B. Tension headache. C. Subarachnoid hemorrhage. D. Cluster headache. Answer: C. Subarachnoid hemorrhage. Explanation: this patient's sudden onset severe headache, described as the worst headache of her life, along with nausea, vomiting, photophobia, and a positive Brzezinski sign, a sign of meningeal irritation, is highly suggestive of a subarachnoid hemorrhage. So is often caused by the rupture of an aneurysm and presents with a thunderclap headache, which is extremely severe and sudden in onset. Migraine and headaches can cause headache and nausea, but they are typically not described as the worst headache and usually do not cause meningeal signs. Cluster headaches are typically unilateral and associated with autonomic symptoms like lacrimation, and they don't cause photophobia or the neurological signs seen here. Question 28. A 68-year-old man presents with difficulty swallowing, hoarseness, and a sensation of a lump in his throat. He has a 40-pack year, smoking history, and consumes alcohol regularly. On examination, there is palpable lymphadenopathy in the neck. What is the most likely diagnosis? A. Gastroesophageal reflux disease. B. Esophageal cancer. C. Laryngeal cancer. D. Zenker's diverticulum. Answer: C. Laryngeal cancer. Explanation: This patient's symptoms of difficulty swallowing, dysphagia, hoarseness, and sensation of lump in the throat, along with his significant smoking and alcohol history, raise suspicion for laryngeal cancer. Laryngeal cancer is common malignancy in patients with these risk factors and can present with hoarseness, dysphagia, and cervical lymphadenopathy. Esophageal cancer could also cause dysphagia, but it is less likely to present with hoarseness and lymphadenopathy in the neck. GERD could cause symptoms of dysphagia or hoarseness, but it wouldn't explain the lymphadenopathy. Zenker's diverticulum is structural abnormality that causes dysphagia but would not typically present with hoarseness or lymphadenopathy. Question 29. A 45-year-old woman presents with a 3-month history of fatigue, weight loss, and a new onset of joint pain. On examination, she has a butterfly-shaped rash on her face and swelling in her wrists and knees. Her laboratory results show positive anti-nuclear antibodies on a DNA antibodies. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Psoriatic arthritis. D. Fibromyalgia. Answer: B. Systemic lupus erythematosus. Explanation: this patient's presentation of fatigue, weight loss, joint pain, and characteristic butterfly-shaped rash, Mallar rash, is highly suggestive of systemic lupus erythematosus, SLE chronic autoimmune disorder. The positive anti-nuclear antibodies on and DNA antibodies are diagnostic markers for SLE. Rheumatoid arthritis, RA, could cause joint pain and swelling, but it presents with symmetric joint involvement and does not cause the butterfly-shaped rash. Psoriatic arthritis is associated with psoriasis and typically involves the distal joints. Fibromyalgia can cause widespread pain and fatigue but would not explain the specific symptoms, including the rash and positive autoimmune antibodies. Question 30. A 60-year-old man with a history of chronic kidney disease presents with a 2-day history of decreased urine output, swelling in his legs, and shortness of breath. His blood pressure is 100 to 100 mHg, and his serum creatinine has risen from 2.0 to 3.5 mgl. What is the most likely cause of his symptoms? A. Acute renal failure. B. Heart failure. C. Acute glomerulonephritis. D. Nephrotic syndrome. Answer A. Acute renal failure. Explanation: this patient with a history of chronic kidney disease and a recent rise in serum creatinine, along with decreased urine output and edema, is most likely experiencing acute renal failure, which can occur in patients with pre-existing kidney disease. The elevated blood pressure is also a concerning sign of fluid retention and kidney dysfunction. Heart failure could also present with shortness of breath, edema, but it would not explain the acute rise in creatinine. Acute glomerulonephritis can cause kidney dysfunction, but it would typically present with hematuria, and nephrotic syndrome would present with significant proteinuria, which is not described here.